Right, well, welcome back. This lecture is going to get into some of the sort of technical issues about how we model the time spent in different health states. But the main thrust is not to teach you the sort of technical aspects, but rather to give you a sense of how sophisticated the analysis is becoming. What at first sight seems a straightforward question, how much time will the patient be likely to spend in different health states in the future, becomes increasingly complex as we look more closely. Now, just to remind you, why are we interested in this? Well, it's all to do with the idea that changing survival of patients is very important. Helping people live longer is important. And I don't think anybody will disagree with that. We might have different views about how important it is if the patient's 95 with comorbidities and things like that. But in general, extending life, lengthening life is thought to be a good thing. I'm very proud of this photograph. It's a graveyard beside the main hospital in Bergen in Norway. And I particularly like the way the lines go in straight lines. I feel it's almost professional, but it was just an iPhone 4S, but still. But that's hence the symbol. The graveyard is obviously death being commemorated, but the thing we're really interested here is survival. Okay. Now, why is it so important? Well, I said this morning, I'll repeat it now. The time that patients spend in different health states will affect the costs of looking after them. The time that patients spend in different health states will influence how many quality-adjusted life years are being generated. So it's affecting the costs and the benefits. Now, to start this off, I've got a sort of motivating example to highlight its importance. And it's a drug called azacitidine for a condition called myelodysplastic syndromes. Now, those of you who are clinically trained, that will mean a lot to you. The rest of us, essentially in this condition, the patient is not forming blood cells properly. And if you stop forming blood cells properly, if they're misshapen, etc., they won't function so well and you have some bad health consequences. That's all we need to know about the clinical aspect of the problem. Throughout, I'll be emphasizing, after the example, hazard rates. And the main hazard we're interested in usually is the hazard of dying. And I'm going to say quite a bit about treatment switching at the end. Okay, so myelodysplastic syndromes, or MDS, essentially your blood cells are reducing. You're not producing new healthy blood cells. And in due course, you're going to have bone marrow failure. As a consequence, you're at increased risk of infection, increased risk of bleeding, increased risk of anemia. And also, there's an increased risk of transformation to something called AML, acute myeloid leukemia. So it's a pretty nasty condition. It's not very common. The UK incidence is, and I'd imagine Japan is probably similar. UK incidence 3.6 per 100,000. Average age at diagnosis 70 to 75. And quite often these patients are fairly frail when they're diagnosed. So azacitidine, a fairly new drug, came on the market just a few years ago, has a market authorization for patients who are not eligible for stem cell transplantation and who have this particular condition. So the technical bit doesn't really matter very much. Essentially, it's just saying you're a fairly severe case, those who are indicated as suitable patients for this condition or this treatment. Now, it's really always the case that clinical trials, from in a sense, an economic point of view, are never long enough. The clinical trial stops too soon. It stops too soon in the sense that not everybody's dead. In a way, what we'd really like to know is when everybody died. But of course, it's not practical to run, or probably ethical, to run the trial until everybody's dead. We specify how long the trial will last, and typically we might either have a fixed period of follow-up, or sometimes you stop the trial when more than a certain percentage have experienced a particular event. Now, there's very good reasons for this. One is to try and minimize patients' exposure to the intervention that you're trialing, because of course it may be harmful, we don't know. And so you don't want to expose too many patients if you can avoid it. More than that, trials are costly, and the longer we run the trial, the higher the cost. More than that, the reason we're doing the trial is to try and establish effectiveness in the hope that we can demonstrate this is a good treatment and introduce it so patients can get the benefits. And so there's lots of good reasons why the trial doesn't go on and on and on. And they are good reasons. But the problem it gives us is we don't know what happens to most of the patients. We know what happens to a few of them. We observe them, for example, dying. And so we need to extrapolate into the future. And this is a statistical procedure, and there's a wide choice of statistical distributions we can use to go from the observed data during the trial to predicting what happens to the patient group over time. And in the next slide, I'm going to compare two different statistical models. One is an exponential model, and the other is what's called a logistic model. And the key point is they produce rather different results. So they start with the same data, they start with the trial data, the observation of what happened during the trial to these patients, and then they predict what happens next. Now this looks complicated, but it's not nearly as complicated as it looks. First of all, exponential model on this side and log logistic on the left-hand side. Along the horizontal, we're measuring time. It's measured in terms of cycles of the model, and roughly speaking in this model, 52 cycles is equivalent to about 5 years. So 270 cycles is in excess of 25 years. So this is quite a long time period, remembering that most of these patients, when they enter this model, are 70 to 75. That's the typical age of diagnosis. On the vertical, in both diagrams, we're measuring cumulative years gained. So this is by surviving the additional years of life that are being gained. Okay, let's take the logistic model first of all. We've got ignore the dotted line just now. The two solid lines, the upper one is drawn for azacitidine, and the lower one, BSC, or best supportive care. So best supportive care is the, if patients get an infection, we treat the infection. If patients need a transfusion, we transfuse them. Azacitidine is the alternative, and that's the new treatment, the active treatment. And so what happens is we take the data from the trial, we observe what happens to these patients during the trial, and to those data points, we fit a curve. And in this case, it's a log-logistic function that's used, and that gives us this predicted accumulation of years of life. Now notice, this azacitidine curve is going up and up and up. It's leveling off a bit, but it's still increasing. That implies that patients are still alive after 25 years. They're still acquiring years of life. We can contrast that with the best supportive care, which levels off a bit sooner, and by, well, what would that be? By about 10 years, virtually everybody is dead and there's not additional years of life being gained. Okay, so those two curves, using a log-logistic model, using the data from the trial, predict for yes?
Yeah. So that comes from a trial comparing azacitidine versus best supportive care.
It does, yes.
How do you know that best supportive care gains, let's say, 1.5 years if it's not compared against no treatment at all?
Right. The cohort are accumulating years of life. So from the point of trial entry, as long as you're alive, you're gaining years of life. So the 0 point is at entry to the trial.
I see. So comparison
that's right.
Someone who dies there.
That's right. And the longer you live, the greater the accumulation of years of life.
Okay.
So compared to everybody, I mean, hypothetically it doesn't make much sense, but compared to everybody entering the trial and just dying, how many years of life are the patient group getting? So this is saying that the patient group who get best supportive care are accumulating years of life, but at a decreasing rate. And by about 10 years, it's not really increasing, and so virtually everybody in that patient group is dead. By contrast, the azacitidine patients are still alive way out here at 20, some of them at 25 years, because the curve's going up and up. Now I stress, that is starting with the observed data in the trial, but applying a particular statistical distribution to it, the log-logistic. Now, the dashed or dotted line is the difference between the two curves, the vertical distance between best supportive care curve and the azacitidine curve. And the difference is increasing and increasing and continuing to increase. Now, this difference, this dotted line, is going to be the main driver of a difference in QALYs between those who get best supportive care and those who get azacitidine. We haven't allowed for the quality adjustment yet. We haven't allowed for what health state the patients are in, but a main driver of the quality difference between those who get best supportive care, those who get azacitidine, these life years are going to be the main driver. Now, we can compare that in the right-hand side to an exponential model. Again, we've got a best supportive care, leveling out, if anything, a bit earlier than in the log logistic model. And the azacitidine is also beginning to level out, maybe about 10 years. And of course, the vertical distance, so the difference between years of life being accumulated between best supportive care and azacitidine, the dotted line, it's also leveling out at a much earlier stage. So we've got a really marked difference here. If you look at the area under the dashed line in the log logistic diagram, it's quite a big area. By contrast, the area under the dashed line in the exponential model, it's quite big, but it's half the size of the log logistic. And so, consequently, you're going to get a much larger estimate of QALYs gained with azacitidine if you use a log logistic model. If you use an exponential model, your estimate is much smaller. Now, the manufacturer went, you won't be surprised, for log logistic model. That was their preferred model. The committee looking at this said, actually, we find the log logistic is implausible. Part of it is so many patients surviving into their 9th decade. These are sick patients. It's not a cure. It's a treatment that helps, but it's not a cure. Whereas with the exponential, the idea that virtually everybody is dead by 10 years seemed much more realistic. And of course, this affects cost effectiveness. The cost per QALY in the log logistic modelling is much lower than the cost per QALY estimate you get in the exponential. So the point of this example is how you go about predicting the future, how you go about extrapolating into the future can be really important. It could lead to a difference between a yes and a no in the judgment of, is this a cost-effective use of resources? Right. So the choice of survival function, in this case log logistic or exponential, is really important in determining the number of QALYs that the different treatments will generate. And so consequently, this is a topic that is quite an area of dispute between a manufacturer who's trying to persuade people that they have a very good product and perhaps a third-party payer who is more sceptical about the benefits, particularly in relation to the cost. Okay. Now, in introducing survival analysis, which what this is the name given to this general area, the key point to realise, I think, is that the data are what's called censored. We have censored data. The end point of interest has not yet happened. In a trial, it sounds very cold-blooded, but the end point of interest is actually death. I mean, we want people to live, we want the drug to work, but actually what we're interested in order to know how well it's working, is people dying. And so the end point of interest is death. And this end point of interest in many trials is not observed. When the trial finishes, some patients are still alive. And so they're what's called censored data. And that has implications for how we analyze the data. We can't use things like linear regression. We need these other models. Survival analysis is very important for economic evaluation for at least two reasons. One is survival analysis can help us identify the treatment effect, how well the treatment is working. And in many models, we are interested in what are called transition probabilities. And these are the probability over time that an individual will move to another health state. The probability, for example, a patient may get better, or in a lot of cancer cases, the probability that the patient will go from stable disease to progressed disease. And these probabilities are used particularly in things called Markov models, which we don't need to get into the technical aspect. They're used to predict the movement of patients through different health states over time. So survival analysis gives us this information. It's very important. The standard approach for taking censoring into account, this idea that when we stop collecting data, there are patients who are still alive and we don't know what happened next. The standard approach to take censoring into account is something called Kaplan-Meier estimates. If you go to a clinical journal and look at a report of a trial, almost always they'll present Kaplan-Meier curves. And almost always in clinical journals, when they report a trial, they use something called a Cox proportional hazards model in order to estimate the treatment effect. So they find things like a hazard ratio of 0.6, which means the intervention has patients dying 40% less, at a rate of 40% less than the control group. Now, these methods that are widely used in the clinical literature to report trials are not particularly helpful for economic evaluation because they describe what happened during the trial. For economic evaluation, we're interested also in what happened next. And so, because we're trying to estimate the time patients spend in different health states, this is done using things called parametric survival functions. And exponential, log logistic, we've just had pictures of, they were both examples of parametric survival functions. Right, now, in my experience, nobody likes equations. Well, that's not quite right. You know, mathematicians like equations, a few engineers like equations, some economists like equations. Everybody else hates equations. So I'm not going to take you through step by step. The only point I want to take from this is that there's a relationship between the survival function and the hazard function. Now, if you think of a survival curve, it's showing the number of the proportion who are still alive over time. That's the survival curve. The hazard that goes with the survival curve is the instantaneous hazard at any point in time So if a patient survives 6 months, what's the risk of them dying now? If they survive 9 months, what's the risk of them dying? That's the hazard. The survival function is showing what proportion made it to 6 months or what proportion made it to 9 months. The hazard is saying, if you survive that far, what's your risk of death in the next short time period? And so for any survival function, there's a companion hazard function. They're statistically related. That's all you need to hold in your mind. Right, so what happens is, as I highlight in the azacitidine example, different statistical distributions, different survival functions give rise to different estimates of life years, ultimately different estimates of QALYs. So there's an issue in how do we choose which survival function to use. Now, what you can do is try, and this is the recommended advice, try a wide range of functions, exponential, log logistic, Gompertz, Weibull. There's a whole series of them. And you can ask the question, how well does a particular survival function fit the data? Now remember the data we've got. We've got this data from the trial, and it's showing for a limited time period what proportion of the patients were alive. And so we then are fitting to those data, we're fitting different survival functions, and you can ask which fits best. But what you often find is different functions fit equally well, because you've only got a short period of data, and a wide range of functions can fit those data points quite well. But these different functions, as we've seen with the azacitidine example, then can go off in different directions, as it were, and give quite different predictions. And so it's probably not just enough to ask, in a statistical sense, which function fits the data best. You've also got to ask a question about the plausibility of the predictions. Which function gives us plausible, believable predictions about the future? And in our example, the exponential model did give plausible explanation, essentially because everybody was being killed off. The log logistic didn't give a plausible or as plausible prediction. So it's not just the key point here is choosing a survival function is not just a statistical issue. It's also got to try and marry up to any other data we have. And for example, here, this is reporting the point at which all high-risk patients in this other trial were dead. And they were all dead by this point. And so that's external data that is supporting the idea that this might be a much more plausible model than this one, where you still have patients surviving. Okay, right. Right, there are a wide range of statistical functions, and they differ largely in terms of how many parameters they have. So how simple or how complex they are. The exponential is the simplest, a single parameter model. There are various 2-parameter models. Log logistic was one of them, the one we just looked at. There's 3-parameter models, there's 4. Indeed, I haven't done it, but you can have a 5-parameter model. These are examples taking the generalized gamma of different hazard functions. Now remember what the hazard is showing. If a patient survives 6 months, 9 months, a year, if they make it to that point, what is their risk at that point of then dying? Now, if you think about it, for different interventions, you might expect the hazard to decrease and then maybe over time start increasing. Or maybe the hazard starts increases to start with as a consequence of the intervention before decreasing. Indeed, sometimes the hazard may just be constant. And so, depending on the particular intervention and the condition we're looking at, different shapes of hazard function will be appropriate. It's a U shape here where the risk of death is really quite high to start with, but if you survive the first few weeks, then the risk falls quite dramatically, and then it might begin to increase slowly over time, or it might go up more rapidly over time. These are all potential shapes. There is, in fact, it's not shown here, there's one called the bathtub. And if you think of a bathtub, it's going to be a very steep decline to start with, and then more or less constant, and then increasing rapidly at the end. And so for some conditions, that makes the most sense. And so I guess what this is highlighting is, in thinking about the distribution to use, you have to think a bit about the underlying condition and what happens to patients. So again, I'm emphasizing it's more than just a statistical exercise. You've got to get the statistics, as it were, to marry up with the clinical information. Right, I'm going to give you one example in a little bit more detail. But as I say, this is not about teaching lots of different, it's not about teaching statistics, but just to give you a flavour of it. This is a very popular distribution. I'm not quite sure why it's so popular. Maybe because it's flexible. It's fairly flexible. And it's called the Weibull distribution. So formally, it's a survival function. Survival is a function of time, and it's specified as the exponential of minus lambda times t to the alpha. So it's, as you can see, we've got two parameters, lambda and alpha. So Weibull was here, one of the two parameter models. Okay. So the hazard function with the Weibull can be increasing or decreasing with time, depending on this parameter alpha. If alpha is greater than 1, the hazard rate increases with time. In other words, the proportion of the group who are dying is rising in succeeding time periods. If alpha is less than 1, the hazard rate is decreasing with time. And if alpha equals 1, the Weibull becomes an exponential model. It's a constant hazard ratio. So it's very flexible, but notice in this model, the hazard can't change direction. It's either increasing, constant, or decreasing. It can't change direction. So here we are, here's some examples. So here's the constant one. And for some purposes, that's a very good model. Constant hazard, at least for the relevant time period. On the other hand, if the patients are quite long-lived, it's quite likely that hazard at some point is going to start increasing, just because older people are more exposed to other comorbidities. So we've got these possibilities. This is a decreasing, and then we've got a couple of increasing ones here. So yeah, the reason it's popular is it's quite simple to estimate, and it's flexible. Right, now the examples we've had so far, particularly the cytidine example, it assumed that a particular survival function was appropriate and it fitted it to the entire period of the data. An alternative approach that's sometimes used is what's called piecewise survival curves. Now the idea here is that what happens to the patients isn't a sort of steady process, but maybe there's different phases to the condition. So rather than fit a single curve to the data points, you might fit 2 or more curves or pieces of curves. So one example here was cabazitaxel, which is treatment, I think it's prostate cancer, metastatic prostate cancer, if I recall correctly. And what they found was that in the data, early on, there were quite a few deaths in the trial from cabazitaxel-induced neutropenia. And then if you survived that first phase of treatment, these deaths ceased. And so the next piece of the survival curve was a different shape from the first piece. The first piece was quite high hazard rate, but it was short-lived. Then the second piece was people dying at a much lower rate. And so rather than fitting a single curve, the manufacturers in this case said, in that first phase, we'll just use the Kaplan-Meier observations, and that'll be our survival curve. But then, in the second phase, we're going to use a Weibull function. So that's a piecewise. And the underlying idea here is that the final piece may be the best predictor of what happens next. And it's got some strong intuition that if some patients are dying very early on, they're not very helpful in predicting what happens to the survivors. Much more useful is the second piece of the survival curve. All the early deaths have disappeared, and we've got a much steadier progress, and using that part of the curve to extrapolate or predict the future. A related idea is to model QALYs, rather than fitting a curve, to take some real data, where you have data, take the observed data, and only use your statistical model to make predictions later on. And there's a bit of a debate going on, should we do this? When we have enough real data, should we not just use the real data and then only extrapolate when we have to? Yeah, I don't think we want to go into Kaplan-Meier actually. Does Kaplan-Meier ring any bells for you guys? If you're from a clinical background, you've probably come across them. Well, if you're more epidemiological or public health, you probably haven't. Well, I think the detail of it, actually, when I think about that, is probably less important. So I think I leave that, and it's another formula. We shouldn't have formula after lunch. It's been around 60 years now. This was the original article in the Journal of the American Statistical Association. What's really quite interesting, if you read the original article, is in those days, it makes it sound like horse-drawn carriages and things, but in those days, they're much chattier, more conversational in the way they write a paper. These days, we're all a bit science-driven. Anyway, I don't think we need that one. The key point is, while Kaplan-Meier takes censoring into account, this problem that we haven't observed everyone die, and so we don't know where the survivors died, the key point about Kaplan-Meier data is it can't really help us in an economic evaluation, because for an economic evaluation, we need to know how long people live and in what health state they live, because that's going to drive the costs and it's going to drive the qualities. And so for that reason, that's why in economic evaluation, we are always using parametric survival functions, the Weibull, the exponential, the log logistic, etc. I do need to say a little bit about this one though. It's a Cox proportional hazard model. Now this is routinely used in clinical trials, or the reporting of clinical trials. And it's partly used because it's sort of nice and simple. The hazard function is given here. Now, there's essentially two parts to it. H naught of t is the baseline hazard function. Now, that's the hazard that is experienced if all the covariates in the model are zero. In other words, if we ignore the age of the patient, if we ignore their gender, other variables such as these, what hazard is common, as it were, to all the participants? And then the second part is where we have particular covariates. It might be patient age, gender, etc. And this allows a specific hazard to be calculated for different groups. So different groups have a particular hazard in common, H naught of t, and then a different hazard depending on things like their age or gender. Now, this is a very popular model because it makes no assumption about the shape of the hazard function. It simply says, whatever the shape is, it's the same shape for everybody. So no assumption has been made about how the hazard's changing over time. This is hazards changing over time. We've got a wide range of different possibilities. The Cox proportional hazards model doesn't make any assumption about that. All it assumes is whatever shape it has, it's the same shape for everybody. It's the same shape for the under 60s as the over 60s. It's the same shape for men as for women. Now, that's quite a strong assumption. And also, when we're comparing two treatments, it's assuming that the patients who get one particular drug, their hazard function will have the same shape as the patients who get another drug. Now, that is a very strong assumption because different drugs often have a different mechanism of action. And if they've got a different mechanism of action, a different way of working, it's highly likely the hazard function will have a different shape for one treatment rather than another treatment. But despite that, people in reporting clinical trials do use the Cox proportional hazards model frequently. So it's important that the proportional hazards assumption is tested. And frequently it's not tested. It's not too difficult to test, but it does involve more equations. The logarithm of the survival function is plotted against the logarithm of time. So log of survival function against the logarithm of time. And if the proportional hazards is met, the curves for different groups should be parallel. And so, if you could almost ignore the blue line, just think of the green line, that's one group, and the red line, another group, that's sort of broadly parallel. But if we look at the blue line, quite clearly the blue line is not parallel to the red line. They converge, indeed. More than that, they cross over. So this would be an example, proportional hazards is not fulfilled. Now the importance of this is, it would then be completely wrong to use a Cox proportional hazards model. It'd be wrong to make the assumption that the hazard that faces one group over time is identical to the hazard that faces another group over time. So far better to estimate separate functions rather than the Cox proportional function. There's another very simple mathematical way. This can be quite hard to interpret. Is that parallel? Is it not parallel? It's quite tricky to say. I mean, in the blue and red case, it's easy because they cross. But in the green and blue, green and red, it's quite hard just to say, are they parallel? You know, they're not totally dissimilar. So another way of doing it is you estimate the logarithm of the relative hazard as a function of these two things. Now, this is the covariate interacted with time, and this coefficient should be equal to 0, because the assumption is the hazard ratio is not changing over time. They've got, as time moves forward, the hazards are moving together, and so there's no effect of the hazard ratio or time on the hazard ratio, and so this should be equal to 0. Yeah, anyway. Right. Okay, so where have we got to? Just sort of gather it together. Trials are always too short for the economic purpose. The economic purpose is to make a realistic estimate of the costs over the lifetime of the patient of one strategy or another strategy. The economic purpose, not just the cost, is also to work out over time how long patients receiving one strategy, one treatment, will spend in different health states compared to the time they spend in different health states with the other treatment. That's going to drive a difference in QALYs. So we need a good estimate of survival to predict this future, so we can make good estimates of the costs and the difference in cost and the QALYs and the difference in QALYs. So that's why we need it. We've got lots of different functions we can use. I've pointed out it matters which one we use. It's not straightforward to decide which one is most appropriate. It can be very difficult. Now, as if that's not enough of a problem, we then come to another problem, and it's called treatment switching. In randomized controlled trials, patients are frequently allowed to switch treatment. For example, when their disease progresses, they'll stop getting the treatment they were getting and they may well be offered the alternative treatment. Now, this is perfectly reasonable. I mean, it's almost like punishing the patient for coming into the trial if you don't allow them to switch. Because if they progress, that drug has not worked for them. So we can't reasonably stop them from switching treatment. Ethically, it's just not appropriate. So that's fine. But that then gives us a problem. If a patient switches treatment, how long they live will be partly a product of the treatment switch. And particularly if we've got a control group such as best supportive care and then an active group, might have been the azacitidine, if the best supportive care patients switch in onto azacitidine during the trial, maybe after they progress, by following the best supportive care group and seeing when they die, or predicting when they die, we're going to get a biased estimate of how well azacitidine works. We're going to underestimate how well azacitidine is working. Now, our estimates of progression-free survival, that period before they progress, will be okay because no switching's happened. But if patients are allowed to switch once they progress, our estimates of overall survival are potentially biased. And generally, it will give us an underestimate. Now, if we underestimate the benefit of azacitidine or any new drug, that is a problem. Because if we underestimate the benefit, we're more likely to say no to whether it's cost effective. And so we could get into a situation where we're saying no to a new drug, but really we should have said yes. So this is a problem. So we need to do something about treatment switching. Do you get the idea that why do we have trials? Randomized controlled trials. We have randomized controlled trials in order to get as good an estimate of the treatment effect as we can. And if all the patients get one treatment, if one half get one treatment and the other half get another treatment, any difference we observe between the two patient groups, we're fairly sure is because of the difference in treatment. Because we've randomized patients at the outset, drug A or drug B. But in the situation where treatment switching occurs, the groups are no longer separate. We've got a group who may just get drug A, a group who just get drug B, another group who get A and then maybe switch to B, potentially even a group who get B and then switch to A. And so we're not getting a clear estimate of the treatment effect. And as I say, risk of, well, I am repeating myself, but it's important. We are really worried about getting a biased estimate of the treatment effect, because if we get the treatment effect estimate biased, we're going to get our quality calculation wrong, we're going to get our cost calculation wrong, and our estimate of the cost per additional quality gained is liable to be wrong as well. In which case we might then make the wrong decision as to whether we should say yes or no.
Question I have. In my view, treatment switching is very complicated because it is very hard to predict what happens if the patient continue the treatment. And another concern is sometimes the cost-effective analysis would be done by pharmaceutical companies, which would be, how to say, inherently biased. How to say?
Yes, they want to make as strong a case as they can for their product.
So, in principle, I'm not sure if ITT analysis is the baseline analysis or, let's say, analysis which consider treatment switching is the standard one. How is the, how to say, the most fair way to handle this problem?
Okay, you refer to ITT, that's intention to treat. So the way we usually examine or analyze trials is when we randomize half the patients to one treatment, half to another treatment, that is our intention, that they'll get that treatment, they'll get that treatment, and then we treat the data as if they got that treatment. And so you're asking, is that the fairest way, or is adjusting the results, because you are adjusting for treatment switching, is that fairer or less fair? Well, ITT, intention to treat, is easier because it's clean. We know at the randomization, this half got that treatment. We're randomized to that treatment. This half randomized to that treatment. But if treatment switching takes place, we can be pretty sure it's a biased estimate we've got from the intention to treat. So I think it's probably better to try and adjust for treatment switching. The problem that arises is there are different methods, and you won't be surprised, different methods can give rise to different results. And so we're in this territory again, which one do we believe? Now, different methods of treatment switching make different assumptions, and it might be that we can demonstrate that some assumptions are more plausible than others. So I might have an example of that here. So as an example of crossover of patients or treatment switching, it's been quite common in some of the trials for renal cell carcinoma. Sorafenib, everolimus, nivolumab, and another everolimus appraisal. So, for example, there's a trial that compares everolimus with best supportive care. It's called the RECORD-1 trial. And 76%, 3/4, of the control arm crossed over. In other words, they were randomized to best supportive care, but during the trial, they switched to everolimus. And the unadjusted hazard ratio, HR is a hazard ratio, so if you like the intention to treat estimate, is 0.82. 0.82. Had the hazard ratio been 1, no difference between the two arms. 0.82 is suggesting lower hazard with everolimus. 18% lower risk of death. Once this estimate was adjusted for treatment switching, in this case using something called IPCW, inverse probability of censoring weights, don't worry about it, just a method. This hazard ratio was reduced to 0.55. In other words, much bigger treatment effect. Now, to my mind, when you've got so many crossing over and you've got such a marked difference between the hazard ratio, our estimate of how well the drug is working, it would be more damaging to just do the intention to treat. To stick with this 0.82 hazard ratio it's really unlikely that this is a good estimate. It's quite plausible that this 0.55 is nearer the truth. And so in doing the economic modelling, I would want to use some adjustment for treatment switching in this case. Now, if this hadn't been such a big rate crossing over, if it wasn't such a marked difference in the hazard ratio, you might feel differently. But in this case, it would seem to be really penalising everolimus if you don't allow for treatment switching. Fact of the matter is, everolimus is not a brilliant treatment for renal cell carcinoma. There are several treatments that are better, but put that to one side. We're not, I think, with the intention to treat estimate, the 0.82, we're not getting a true picture. I've got some, I don't know if this comes out very well. It's one of these things where it looks good on the screen, my screen, doesn't always look so good on other people's screen. Yes, anyway. Sorry, this is control treatment and intervention. Okay, and so these blue arrows, if you like, PFS, progression-free survival, PPS, post-progression survival. And so what's happening here is that the control, patients getting the control treatment have a particular period of progression-free survival followed by a particular period of post-progression survival. By contrast, patients who get the intervention are having a longer period of progression-free survival, the drug is working, and a longer period of post-progression survival. Now, if that's the case and there's no crossover, this difference here, and I do wish I'd used black and not white, is our estimate and is indeed the true overall survival difference. So if all the control treatment just got the control treatment and nothing else, if the intervention group got the intervention and nothing else, the trial would give us this estimate of overall survival difference, and it would probably be pretty accurate. Now, the problem caused with treatment switching is that some patients start in the control but then go on to the intervention. And so, while they might have a similar progression-free survival, because they switch after progression, their post-progression survival is being influenced. Because they're getting the intervention, they're getting some of the benefit of that intervention. As a consequence, their post-progression survival is much better than if they'd remained in the control group. And so, what we observe is this difference from the trial, the randomized control trial overall survival difference. So what's happening, because the patients crossed over, it's inflating their survival. And by doing that, it reduces the difference compared to the intervention group. That's the basic problem.
No question.
Please.
Do you mean that we may have a hypothesis that if the patient got progression, the patient gets treatment and patient in control group will be different when they get progression? You mean the PBS in the treatment group may be longer than PBS in the control group? I mean, their progression are different.
Yeah, right. So in this example, the control group and the intervention group are progressing on average at a different stage. So the intervention group are doing better. At this point when patients progress in the control group, if they don't switch treatment, they have this relatively short post-progression survival. If they do switch treatment, they get this longer survival because it's assumed that the other treatment is beneficial to them. And so as a consequence, if we just don't do any adjustment, we're going to estimate a smaller difference in survival. Whereas if we do adjust this, if we somehow manage to allow for the crossover, we can get back perhaps to the true difference. That's what's happening. Now, of course, in this example, everybody switched over. You know, this group don't, as it were, exist. Everyone switched over, and we just observe this difference. In practice, of course, some people in the control group will remain like this. Some will switch over. And in the real-world example we just had, this record 1 trial, 76% switched over. So in other words, 3/4 of the patients had this experience, control followed by intervention, and 1/4 remained in the control group.
So I could be wrong, but as far as I understand, IPCW assumes something similar to missing at random, that is, the transfer to the other treatment is dependent on the other covariates, and which means that if everyone switches, you cannot calculate IPCW.
Yes, you could not. I'm not going to get into the detail of the individual methods, but that is true, yes. Ideally, for IPCW, half would be nice. If half switched and half didn't. But yes, if they all switched, you couldn't estimate it. And indeed, if a high proportion switch, that 76% is getting a bit high. But that's what the manufacturer argued for. Yeah. So what can we do about treatment switching? Well, there's no universally agreed solution. There are naive approaches, do nothing, exclude the patients who switch. These are definitely not recommended. They do nothing because we're going to get a biased estimate if we do nothing. The excluding patients who switch is highly prone to bias because patients typically don't switch at random. They have a reason for switching. And so the group who switch, in that sense, are almost signaling they're different from those who don't switch. So that would be a problem. If you just excluded the switchers, you're left with a biased group. There's a number of more or less complex statistical methods. One we've mentioned already, inverse probability of censoring weights. Another one is rank preserving structural failure time models. I don't know who thinks up these names, but and another one, easier one, is using a secondary baseline. Now, I think I'm just going to have a little look at the secondary baseline because it's the easier one to explain. As I've alluded or suggested already, it's quite common for switching only to happen after progression. It could happen any time, but it's quite common indeed to design the trial that you don't allow switching until patient progresses. Well, that's reasonable enough. You know, if they haven't progressed, you're not really penalising them. But once they've progressed, if you withhold the other treatment, you would appear to be penalising them. And this is definitely the case in oncology. So if switching only happens after progression, we can consider a two-stage process. And we can use the point of disease progression as a secondary baseline, or a new baseline. Let's look at this graphically. Yes, why didn't I put it in black? Anyway, here we have control group who are then ultimately non-switchers, so they stay in the control group, okay? And they experience a particular period of progression-free survival on average, then a particular period of post-progression survival on average. The next group here are the control switchers, and so we assume, there's no reason to believe, they'd have different progression-free survival. But once they progress, this group switch to the other treatment, and we anticipate, as a consequence, have longer post-progression survival. So, under this approach, we identify a secondary baseline. So the original baseline was at this point, entry to the trial. We're now identifying a secondary baseline. That's the point of progression. And so what we can do is estimate a treatment effect in switchers compared to non-switchers. And switchers are doing a bit better than the non-switchers. So what we now want to come up with, this is just those two things moved up a bit, made space down here. We're coming up with a control counterfactual. Now what we mean by a control counterfactual is what would have happened if people hadn't switched? What would have happened if they hadn't switched? And to create this, what we're going to do is reduce the estimate of post-progression survival that the switchers experienced. And so we're reducing it back down. That's the principle. It makes a particular assumption. All these methods make assumptions. The key assumption is that there's no unmeasured confounders at the secondary baseline. What does that mean? No unmeasured confounders at the secondary baseline. Well, here's the secondary baseline. What this model needs is we need to be able to control for any differences between the two groups. Control for differences between switchers and non-switchers. And by assuming no unmeasured confounders, that means there's no other factors that are different between switchers and non-switchers. Everything is observable, and it might be switchers are younger than non-switchers, or whatever. But it's quite a strong assumption, and indeed untestable. But if we can make that assumption, this use for secondary baseline is one way to adjust for treatment switching. The other methods also have strong assumptions. Rank preserving structural failure time model also makes an assumption about no unmeasured confounders. No, it makes assumption about common treatment effect. Common treatment effect, yeah. What this one assumes is patients who switch get the same benefit from the new drug as patients who get the new drug straight away. say that again. Patients who switch get a benefit from the new drug, and it's similar to the benefit they would have got if they'd got the new drug straight away. Now, that's another strong assumption. Because, of course, the patients who switch are a bit sicker now, and so maybe they're past the point of being able to get the benefit. So the key point, however, is all these methods have to make assumptions, and these assumptions may be quite strong, and so there really isn't any perfect method. And we're at quite an early stage in identifying in which circumstance one method's better than another.
I have a question.
Yes.
When I read this one, it's like that we try to find all the benefits of the intervention. But also read some papers show that after the patient got regression with the intervention, when they treat with the intervention again, the progression-free survival will be shorter, much shorter than that previous. So I just wonder, maybe these patients, they may have no other choice. There is no better drugs for them. They may choose some worse drugs or use the same drugs, but they get less benefit. So, I mean that their overall survival should be shorter than what we expect.
Yes, I mean, I think that speaks to this common treatment effect. The assumption that patients who switch get as much benefit as they would have got if they'd received it to start with is strong assumption, maybe quite unrealistic. I know a lot of clinicians, at least in the cancer area, almost as a rule of thumb, assume that as you move through different lines of treatment, the amount of benefit you get halves. Now, that's not always true because some drugs have very different mechanisms of action. And so if they have a very different mechanism of action, it's more plausible that you could still get the full benefit. But if we're thinking of drugs that have a similar mechanism, it becomes highly implausible that you'll get the same benefit. The benefit's going to reduce over time, yeah. But whether it's the same or reducing or how much it's reducing, that's the issue. We're trying to get as true an estimate of the benefit of a therapy as we can. And we don't want to underestimate the benefit, but we don't want to overestimate. So it's really quite a challenge. And it's an area where we're still learning. In a sense, we're at a fairly early stage just now. And, as if that's not tough enough, regulators are approving therapies earlier in development. So, for example, certainly the European Medicines Agency and the FDA, Food and Drug Administration in the US, are beginning to fast-track particular drugs and approve them on the basis of less evidence. Sometimes just stage 2 evidence rather than stage 3 trial. I don't know if this, I'm not sure the same's happening in Japan yet, but if it's not happening, it will be happening. It will happen. Regulators, they want to, naturally, they want to get new drugs approved. And there's quite a push going on for that. Now that implies we're going to have poorer data in the future than we even have just now. And so it's going to get tougher to make accurate estimates of how effective the drug is. So that's a real problem. Okay, let me just get to the summary. I keep banging on about this point, but it's really important. Economic evaluation requires a prediction about the future, because we don't really care what happens just during the trial. We need to know what happens during a trial, but what happens next. If we're to get accurate estimate of the costs and benefits, we have to look into the future. So that's all right. But the first problem is different methods will give rise to different answers. Different assumptions about which statistical distribution to use, or different ways of adjusting for treatment switching. They'll lead to different answers. Now, over time, and I've noticed it, well, I suppose I've been doing this for years, but even in the last 10 years, there's been quite a marked increase in the sophistication of the methods being used, which is good. It's good in the intellectual sense, it's interesting, it's challenging, but in the practical sense, it's good if our methods are getting better. But, as I've just alluded to, maybe the data is beginning to get poorer. Now that's a real worry. Now, there's a lot of publicity given to things like real-world data, and the idea that data increasingly might come not so much from trials, but maybe at least supplemented with observation of real patients just out there being treated. Observational data. That's quite encouraging in a way, that we should collect better data on real patients, because the patients in trials, I haven't said it, but as we all know, the patients in trials are highly selected, and they have very few comorbidities. They tend to be younger than the patients in real routine clinical practice. And so it's good that we're embracing real-world data. But of course, then you're embracing real-world confounders. At least in the trial, you've got very good data on people, what previous treatments they've had, etc. In the real world, you typically have much poorer quality data. So it's an interesting time, but a challenging one. Okay, so what I'm going to talk about tomorrow morning, Thursday's the day off this week. Tomorrow morning, I'm going to move this forward. I'm now assuming we've been able to model the time patients spend in different health states. We've solved all those problems. What we now need, if we're going to get the QALY, is the QA bit, the quality adjustment. And I want to introduce you to some of the issues and some of the progress we've made in doing that quality adjustment, in measuring patients' health states and giving a score to their health state. And then in the afternoon, I'll look at alternatives, such as money. Why on earth are we wasting time with all these QALYs? Why don't we get straight down to it and use money to value health? And there are some good reasons, but we'll look at them. Okay? So we resume tomorrow, same place, same time. And I hope, 3 hours of me is quite a lot to put up with. So I hope you get a good rest tonight, okay?